we can do, if there is normal diffusion but the patient is definitely symptomatic, repeat diffusion. Immediate, no abnormality, after 12 hours, diffusion positive, or signs. Okay? Or we change the plane. This plane is not visible. In coronal plane, there is signs. Now, what is apparent diffusion? Apparent diffusion coefficient. Adiabatic is quantitative scale of diffusivity. These are basically for practice, not for practical purpose, basically theoretical purpose. You may not feel well, but still I have to say. The areas of restricted diffusion are seen as dark on adiabatic, just reverse of diffusion, what I have shown. And the areas of infarction will show decreased ADC values compared to the normal diffusion. And how ADC help in normal diffusion? ADC maps have low sensitivity and is not important to check activity. So if it is diffusion, if diffusion is negative, you do not need to go for ADC. Okay.
Sir, one question, sir. So in case of early stroke, as you have shown in earlier pictures, so first one is the DWI negative, and the repeat scan shows the DWI positive. In that case, whether ATC is required?
Initially it was negative.
Initially it was negative. After 12 hours it was positive.
Yeah,
so in that case, ATC map can help.
Okay, I'm coming again. There are a lot of issues of distribution. Okay. So diffusion equal to infarct. Is it true? Okay. Everything that science is not always true. But these are the problems. Is it a true infarct or any artifact? These are normal artifacts what you get in temporal lesion. So all the science happens is not equal to diffusion point. You have to put that initially what I have stated on the very next slide, the second slide, I told there should be interdepartmental dialogue. Unless you give me the clinical input, basic and essential clinical input, I'll say okay, it is diffusion point. Without knowing the patient is suffering from stroke. That is very clear. Okay. Now, what are the pathologies which have to drive on diffusion? There are not only the infarct, there are other pathological factors where you get diffusion caused. In heart electrophysiology, acute multiple sclerosis, diffusion axonal injury, pyogenic abscess, and epicarditis. Now, TI, what's your TI? Just define TI.
So it is the focal neurologic deficit present for up to 24 hours, which is reversible.
Is it still valid? Is this definition still valid today? The definition is under threat. Because defined as you have told, as per your definition, the TI patient, 50% will show diffusion positive, 50% negative. 50% fully reversible, 50% will go to the complete stroke. This is accepted and proven fact. So, clinical BIA patients versus clinically completed stroke patients. In TIA patients, the ADC volume, mean ADC value, diffusion volume, there are so many parameters that are all significantly less abnormal than acute stroke patients. We have to check. And actually, definition of TIA is that all mini stroke should not be ignored or TIA should not be ignored. Okay, the patient will recover in 24 hours. The patient may progress to complete stroke to 50%. Now, mimics of TIA. Migraine, hyperventilation, or a brief spell of seizure. So in these cases, positive diffusion will help you to differentiate from TIA or infarct. Lacunar infarcts, as I've shown you, there are multiple infarcts. But which one is the offending one? Then you have to take help of diffusion. Which one is the recent or which is causing monoparesis or monoplegia? See, there are multiple low density areas. I will have the interchanges, CT2. But which one? Only diffusion can say yes, these two are hyperactive. These are the offending and recent one, which is causing the symptom. Again, the issues of intracerebral hemorrhage versus hemorrhagic infarct, non-hemorrhagic infarct versus hemorrhagic transformation, petechial hemorrhage versus microbleeds, this can be detected in diffusion. Diffusion positive, but look at this one. There is a hypointensity area. In clear image or photon density image, there is hemorrhagic transformation. So with diffusion, you can say, look, there is ischemic changes of recent onset, but also there is hemorrhagic transformation. Now venous infarcts, I'm not going details into it. Just I'll skip because there are a lot of issues again I have to cover. Look at this picture. It is low grade glioma. It is not T1. Diffusion? No signs of appearance. So diffusion negative. Diffusion positive. Diffusion positive. Not conforming to any vascular territory. So it is a venous or this type of infarct happen in case of immunocompromised patient, not in particular arterial change. If you get this type of infarct, not conforming to any particular arterial change, think of venous infarct or rule out whether the patient is immunocompromised or very atypical type of infarcts. Again, infarct without thrombus, thrombus without infarct, and all of them. Shall I go? I think this will be more common. Okay. So what we have learned from this one, that diffusion helps early detection of ischemic changes in the particular part of brain. And penumbra imaging is possible to shape the penumbra or reversible. It can be reversed back to normal and maximum damage can be reversed. So that is the importance of diffusion. Provided you have got the adequate infrastructure to treat the patient. Because not all patients are fit for thrombolytic care. Now, as far as CT angio is concerned, CT angio, in fact, almost for screening, say, in cardiac, say, for screening purpose, it is walk-in, walk-out procedure. You don't have to now, with the 64 slice, 50 slice is no longer used. At least you need 64 slice CT machine, but you don't need to refer the separate patient's heart rate or patient, even if patient is arrhythmic, it can be done without any artifact production. And CT angio for pulmonary CT angio. Okay. Similarly, for CT angio for brain is sufficient. Walk-in, walk-out procedure within 15 minutes it can be completed. But or three-dimensional time of rapidity of plus CT angio, both combination improves. Then MR with MR angio alone. MR angio with 3-dimensional time of flight and CT angio together gives more accurate information of the intracranial topography. This is the pictures of CT angio. Again, plaque morphology can be picked up, as I told you, that calcium scoring, if it is soft plaque, that is more vulnerable plaque, that can be picked up in CT angio. If it is calcified plaque, that also can have calcium scoring, and we can see, but MR is not possible. The CT angio has got certain regularity of stroke clinics, as you all know, brain tumors, or 3% of patients with brain tumors may present with stroke, demyelinating conditions, total analysis, migraine, Bell's palsy. Now, so the take-home method is the learning for. So go for thin diffusion under image, coronal and sagittal. Always keep in touch with the neurologist. Is it hemorrhagic? So gradient echo-imaging or diffusion under image, arterial or venous. You go for diffusion, MR angio, MR venom. Is this really infarct or something different? Go for contrast, MR spectroscopy, perfusion. And also, you have to apply your clinical judgment and see. And that's why the files of the technical will be dialed.